Penicillins marked the birth of modern antibiotics almost 100 years ago and remain a cornerstone of antibiotic therapy today. Penicillin G, or benzyl penicillin, was the first penicillin used clinically. Widespread use began in the 1940s and revolutionized the treatment of bacterial infections. However, penicillinase-producing organisms, that is, bacteria that produce an enzyme that breaks down the beta-lactam ring of penicillins, immediately limited its use against Staphylococcus aureus, E. coli, Klebsiella species, and other organisms. In general, penicillins are less effective against gram-negative organisms, which have an outer membrane that acts as a barrier, blocking the penetration of penicillin. Despite these challenges, Penicillin G maintains excellent activity against several important pathogens in neonatal infections, including Group B Streptococcus, Streptococcus pneumoniae, Enterococcus, and the spirochete treponema pallidum, the bacteria that causes syphilis. In neonates, Penicillin G is used primarily for the treatment of congenital syphilis and directed therapy for susceptible gram-positive infections. If we need empiric Streptococcus or Enterococcus coverage, we'll typically use a penicillin with a broader spectrum of activity than Penicillin G. Early resistance to Penicillin G spurred the development of anti-staphylococcal penicillins like methicillin, oxacillin, and Nafcillin. These penicillins were specifically designed to resist penicillinases produced by Staphylococcus aureus, and are therefore effective against methicillin-susceptible Staphylococcus aureus, or MSSA, as well as some Streptococcus species. They are mainly used for MSSA, bacteremia, and meningitis in neonates, as they have good CNS penetration and are very narrow spectrum. They are also being investigated as part of combination therapy for empiric late-onset sepsis. In the 1960s, the third generation of penicillins, called aminopenicillins, was introduced. This class includes ampicillin and amoxicillin. Ampicillin remains one of the most commonly used antibiotics in neonates, as it has excellent gram-positive and some gram-negative coverage. Compared to earlier penicillins, ampicillin offers coverage against gram-negative bacteria like Haemophilus influenzae and E. coli, thanks to their improved stability to penicillinases. However, resistance remains a challenge. In neonates, about 50% of E. coli and Klebsiella pneumoniae strains will be ampicillin resistant. Because its coverage against gram-negative organisms is hit or miss, it is used in combination with an aminoglycoside like gentamicin for broader coverage for empiric early-onset sepsis management. In some institutions, this combination is also used for empiric management of late-onset sepsis. Ampicillin is also utilized for directed therapy against Group B Streptococcus, Streptococcus pneumoniae, susceptible Enterococcus faecalis strains, and Listeria monocytogenes. It has good CNS penetration at higher doses, and so it can be used to treat neonatal meningitis as well as bacteremia. Adding a beta-lactamase inhibitor to the aminopenicillins further expands their coverage against resistant organisms. Combining ampicillin with sulbactam, or amoxicillin with clavulanic acid, adds coverage against MSSA as well as gram-negative anaerobes like Bacteroides fragilis. These combinations also have more reliable gram-negative coverage, including beta-lactamase-producing strains of E. coli and Klebsiella pneumoniae. Of note, we don't usually utilize amoxicillin except for UTI prophylaxis in infants less than 2 months of age when indicated, as bioavailability in neonates is unpredictable and not well studied. The last generation of penicillins includes the uridopenicillin piperacillin, usually paired with the beta-lactamase inhibitor tazobactam to further extend its spectrum of activity. allowing it to overcome enzymatic breakdown by some beta-lactamases. It also has similar spectrum to Ampicillin-sulbactam, but with broadened coverage against gram-negative bacteria, adding Pseudomonas, Enterobacter, Citrobacter, Serratia, and Moraxella catarrhalis coverage. In neonates, Piperacillin-tazobactam is typically used when a gastrointestinal infection source, like necrotizing enterocolitis, is suspected, or when there's concern for Enterococcus or a ceftriaxone-resistant gram-negative organism specifically. Penicillins target the bacterial cell wall, which has a protective mesh-like structure made of peptidoglycan. Peptidoglycan's main function is to preserve the cell's integrity and prevent macromolecules from getting into the cell. Penicillins specifically inhibit the action of the transpeptidase enzyme, also known as penicillin binding protein, which is essential for building the bacterial cell wall. By mimicking the substrate for the enzyme, the last two dealanine residues of the peptide, penicillins irreversibly bind to penicillin binding proteins and prevent the cross-linking of the peptidoglycan strands, leading to a weakened cell wall and eventual cell death. While penicillins are generally well tolerated, they can cause side effects such as rashes, seizures, and kidney or liver dysfunction. Ampicillin in particular may also cause diarrhea, and Nafcillin can lead to neutropenia or anemia. Fortunately, these side effects are relatively rare. Also of note, allergic reactions to penicillins are particularly uncommon in neonates and are seen much more in children and adults. From their discovery nearly a century ago to their continued use today, penicillins have shaped the way we treat bacterial infections. With a range of penicillins available, each class with their own spectrum of activity, these antibiotics are still a powerful tool in combating neonatal infections. Thank you for watching. Please let me know in the comments what topic you'd like me to cover next.